the next talk by Dr. Sangeet Mittal, dealing with hypotony in patients of uveitis, which is always the most disastrous complication of patients, especially with chronic uveitis. So Dr. Sangeet is a very well-known retina consultant at Thin Eye Hospital, Jalandhar, and it will be a delight to see his videos.
Thank you, Dr. Manisha, for giving me this talk, and good afternoon, everyone. So I'll be talking upon surgical management of hypotony, and I've included videos also beyond uveitis also in patients like trauma, post-traumatic cases. But chronic hypotony, what do you define is IOP less than 5 millimeters of mercury, which is prolonged. And it may be a result of glaucoma surgery, retinal detachment, choroidal detachment, ocular trauma, chronic PVR, chronic uveitis. They all cause chronic hypotony. And the consequences is like chronic pain you'll be having, then bad appearance of the eye, corneal edema. There could be hypotonic maculopathy, optic neuropathy, and even phthisis bulbi. And so you have to prevent this by increasing the IOP in some way, and most of the times we are able to do it conservatively by medical management or by giving intravitreal injections also, but sometimes you may need surgery to treat this condition. And various surgical options include the cryo adhesion, the repair of leaks, the choroidal drainage, vitrectomy with gas or silicone oil, epiciliary membrane removal, cyclodialysis, the cleft closure. There are also reports with the anterior encircling band. And there is a substance which is called foldable capsular vitreous body, which is not yet available in India and can be done. So this is one case. This was a video given to me by Dr. Vipin Vig. And this was a 16 years old girl who had a scleral coloboma. And there was a chronic hypotony in this case. And when he started to the vitrectomy, you see there is fluid leaking from one side. So lensectomy he did in this eye, and when he removed the lens, he found that there was a scleral defect over there from which whatever fluid was there was going out. And surgical options in this case include to close that defect by amniotic membrane, fibrin glue, gel foam, or sclerograft Tenon's patch. I myself have no experience of doing this, but if anybody has, can discuss this after this presentation. Next is choroidal drainage, choroidal drainage which causes hypotony. If you drain the choroids, if you are able to do
controlled cannular drainage is a simple technique using a 26-gauge intravenous catheter for drainage of suprachoroidal or subretinal fluids. A 26-gauge intravenous catheter is taken and inserted.
This is my method, what I use to drain the choroidal and suprachoroidal or subretinal hemorrhage.
The tip of the catheter is then visualized and confirmed to be in the right space. Once confirmed, the plastic cannula is then advanced forward while the metallic trocar is withdrawn.
This is how you perform this.
The fluid is seen coming out of the cannula. The cannula is then connected to the extrusion pump of the vitrectomy machine so that the speed of drainage could be foot controlled. This is a case of post-trauma intraocular foreign body with choroidal detachment and hemorrhage. Due to massive choroidals, there was no space to perform proper vitrectomy. Controlled cannular drainage was done in fast mode to create space. The speed of drainage was reduced as the choroid became flat to prevent any tissue incarceration.
So this is how I do a choroidal drainage. Then sometimes you need to do vitrectomy with silicone oil injection in these eyes to maintain the globe pressure. And in uveitis patients, one has to be careful, like the vitreous which is there is in gel form. And it's not like normal vitreous, and it appears as a gel form, and you have to take care about that. And triamcinolone in these cases may not stain posterior hyaloid because it's a sheet-like posterior hyaloid, which is not rough. And triamcinolone, mind it, does not stain, it just adsorbs on the surface of the vitreous. So it may not stain the posterior hyaloid. So you have to take care. And sometimes PVD is induced while you are doing the ILM peel. You realize that still there is the layer of posterior hyaloid over there. And so when we start the ILM peeling, we come to know of this layer, and then we can remove this. So in one case, this was a patient who had an hypotonic maculopathy. You see there is ILM folds near the macula. And he had a chronic hypotony, and in which we had gone in to treat her with vitrectomy and silicone oil injection. ILM peeling was done, and in this patient, silicone oil was injected. And this patient post-operatively had a good IOP buildup, and she maintained her eyesight after that. Then Dr. Mudit has shown endoscopic removal of cyclitic membranes, which can be done. And this was another patient of chronic uveitis with chronic hypotony, and she had all these membranes in the ciliary body area. And this case, forceps was used. This is a 23 gauge forceps which was used to peel off these membranes. But as Dr. Mudit and Dr. Manisha pointed out, there is a lot of risk of bleeding, and so you have to go very slow. You may desegment these membranes into various parts and then remove one by one. But endoscope is not available to all of us. We can do a under microscope visualization also, we can try to remove these membranes. The trick is that you decrease the IOP to a very low, like I am doing at around 5 millimeters of mercury here, and depress the ciliary body, and one by one you can remove all these membranes slowly. So this is another way you can use your microscopic view to remove these cyclitic membranes. Sorry. So this is a video by Dr. Manisha Agarwal. How to repair the cyclodialysis cleft if it is present. And you have the video or audio also.
Injury to the right eye and vision of 624N24 and a pressure of 2 millimeters of mercury. There was subluxated lens and hypotony maculopathy. There was 360-degree cyclodialysis cleft. We present the sewing machine technique to repair a cyclodialysis cleft. Lensectomy and vitrectomy was done, followed by intraopgonioscopy to confirm the extent of the cleft. A scleral flap was made and 10-0 proline suture was threaded into a 26-gauge needle, and the needle was cut off. The needle with proline suture was passed through the cleft, and a loop was taken out, which was kept in place with the help of a 30-gauge needle. This was repeated multiple times, and multiple loops were taken out, which were kept in place with the help of the 30-gauge needle. The 30-gauge needle was extended to keep all the loops in place, and the suture was finally pulled out. And the tenoproline suture was then passed through all the loops. The 30-gauge needle was removed and the suture was tightened. The follow-up at 12 weeks showed a vision of 69N6 with an intraocular pressure of 18 millimeters of mercury.
And she had repeated it on the other side also, just due to the paucity of time, can't show it. You can do anterior encircling bands in cases of cyclodialysis cleft, and there have been studies which showed that this is also sometimes helpful. A simple encircling band, just you have to make the anchoring tunnels just behind the aura or just behind the muscle insertions. And nothing much more in it. And this was a post-traumatic eye, and he had an improvement in intraocular pressure after that. This is the last video.
This is foldable capsular vitreous body.
This is to courtesy
Air is
Dr.
being
Hussain
injected
Khan
to
from
inflate
Pakistan.
the foldable capsular vitreous body. After checking any leakage underwater, foldable capsular vitreous body is deflated and folded. Foldable capsular vitreous body is put into dedicated FCVB injector. Mm sclerotomy is done to inject the foldable capsular vitreous body into the vitreous cavity.
This is done in all gone cases, like to
Position
prevent
of
thysis bulbi in
FCVP
these
drain
eyes.
tube is secured with Ethibond suture. The silicone oil is injected into the capsule via a drain valve.
Thank you.
Thank you so much for telling us of various techniques how to